Our next speaker is going to be Erica Doubleday, and in keeping with protocol, New Orleans girl, grew up in Destrehan, went to Mount Carmel. She got both her bachelor's and master's in nursing at LSU School of Nursing and has been working at Ochsner since 2014. And so I will turn the floor over to you.
Thank you. I want to thank all of you for hanging out to the end of the conference. Greatly appreciated. I'm sure most people are just in it for the crawfish in a little while. But just like Dr. Ellis said, I'm Erica Doubleday. I've actually been at Ochsner since 2010, and just to give you a little background, I started as an oncology nurse in the infusion center, and then I did bone marrow transplant as a nurse practitioner, and I now do breast cancer. So we're going to talk about oncology urgent care triages for nursing. I just want to let everybody know I have no disclosures. This is our agenda, but really I went way back to basics of nursing. I'm finding the nurses that are coming out of school, they're pandemic trained, they're pandemic educated, and it wasn't nearly as hands-on as I think some of us back in the past used to get. I've had a nurse recently tell me they don't recommend that you go to a med surg floor anymore. They say, hey, go to your specialty, learn your specialty, and get really good at it, which I like that idea. I like that we're coming out with nurse fellowship programs, but I'm also finding some of the training we're lacking there. And so I really wanted to go way back to the basics, go over the things that most of our patients actually experience, and how these nurses can triage them. We're now getting more and more patients that have access to us, whether it's with Epic and MyChart, and they can message us directly as the providers, or whether we have programs like Chemo Care Companion, where we're monitoring their vital signs from the hospital. They're at home taking them. We're shooting them a message, asking what's going on. So there's a lot more access to us as providers, and we really need our nurses to be that frontline staff to be able to help us kind of navigate what does this patient really need. I don't need to see that the patient wants to come, an hour later or something of that nature. What I do need to know is what are their side effects? Have they kind of been walked through what they should already know and then come to me? So we're going to kind of go over all of that. I really like Troy. I think he already left the room. But fatigue, chemotherapy fatigues, unlike any other fatigue. One of the biggest things we recommend is exactly what Troy says, light exercise. If patients exercise I usually say 15 minutes twice a day. 30 minutes for these patients can be a lot going through chemo and radiation. So I usually say 15 minutes in the morning, 15 minutes in the afternoon. It does tremendous help for these patients. A couple of other remedies that they can do, hydration. I think it's really hard for us who are not going through cancer treatment to drink the allotted amount of water we should. So to expect our patients to do that, sometimes it's easier to tell them 4 regular water bottles a day. Doesn't have to be water, Gatorade, Powerade, Pedialyte. Now they have liquid IV hydration that they can drink. Something outside of just water, because that will make patients drink a little bit more. Encourage them to rest throughout the day. I think they feel like, especially younger patients with families, that they need to get up. They need to do their regular activity. They need to do everything they can. But they need to take the naps. They need to give their body the rest and rehabilitation. And then eating well-balanced, high-protein meals can also help. So one of the things I always recommend my nurse to do is have these at the forefront of the mind when the patient's right in. So that way you can ask them, have they done all of this? If they've done all of this, we need to check a CBC. We need to know those regimens that are really going to hit the bone marrow hard, particularly your leukemia, your lymphoma, your adriamycin regimens. Check a CBC. Do we need to give them some blood? Now, I went way back old school. This is technically for pain, but I think it applies to a lot of side effects that you can experience when going through chemotherapy. So I'm trying to educate our nurses to go back to triaging the patients. Ask these questions. When was the onset of it? Location may not be applicable to most things. We know where constipation's happening. We don't need to ask the patient. But duration, characteristics, alleviating factors, things they have tried, things that have not worked, the timing of it, and the severity. Being constipated for a day is very different than being constipated for 5 days. So we'll hop right into nausea and vomiting, something I think that we've really been able to control really well over the last several years in oncology with new medications like olanzapine that we're using for patients. But some of the things that I'm trying to teach our nurses to do: check your antiemetic medications. Just this week, everything is built into Epic where I work at Ochsner. Our pre-meds are built in. We just have to send them. I have an old school physician I work with who insists on sending them himself. When I read the prescription, sometimes I'm like, I don't even know what you mean. I don't know how to take this medication. So a lot of patients will write in and say, I don't know what the day before chemo, do they mean literally the day before? Do they mean the day of? So make sure that their medications or their antiemetic prescriptions are written correctly. Are they using them as prescribed? We give them PRN medications. Are they actually taking the PRN medications? Are the PRN medications I'm prescribing, like Zofran, causing constipation so they're not taking it? Do I need to give them something else to help with their nausea? And when did their nausea start? Is this something that's preemptive before their chemo? Is it really anxiety, or is it nausea related to their chemotherapy? What is really the basis of what's causing these symptoms? And then for me, I can say I rarely get patients this day and age that have vomited. So are they vomiting? Do we need to reevaluate what their diet looks like? Are they eating foods that are causing them to vomit, such as spicy foods, hot foods, highly acidic, greasy, fried food? Homegirl up here loves your fried food. Probably shouldn't eat it while I'm going through chemo. A couple of the other recommendations: drink your liquids. You're going to want things like ginger ale, tea, broth, 7-Up. Eat dry, bland foods, really boring foods without a lot of flavor in them. And then a reminder, know your highly emetogenic regimens. I find our nurses these days, they can triage sometimes, but they're forgetting what regimen these patients are on. Did they get adriamycin? That might cause a little bit more nausea than some of your other regimens. Next is constipation. Again, go back to old carts. You can really use that to try and guess or try and get the answers to the majority of what you need to know from these patients. When was your last bowel movement? What was the consistency of it? Constipation, by our definition and your patient's definition, may not be the exact same. Are they on a pain regimen, but we forgot to put them on a bowel regimen? That's on us. They don't know that. We need to make sure anytime we're starting pain medications, we're educating them that they also need to be on a bowel regimen. And then again, antiemetics. Are we giving them an antiemetic that's making their constipation worse? Do we need to try and change that? When I'm teaching my patients, we have a book, we give them a list of the over-counter medications. I try to use the name of the medication they're used to. So your Senna, your Dulcolax, your Colace. If we use some of the other names, I think we confuse the patients. So trying to use it in the terminology that they're aware of, I think, is best. And then food recommendations for these patients. Eat high-fiber foods. Drink your water. Again, 4 regular water bottles a day, 2 to 3 liters of water, and exercise. So 20 to 30 minutes a day can also help with the bowels. Diarrhea, similar to constipation, you have to ask the patient to clarify what is their definition of diarrhea. Again, our definition is going to be very different sometimes than them. A change in bowel habits for patients can be a little bit scary. They get a little bit nervous, they wonder what's going on, they're not used to it, so they're going to write in, they're going to tell you it's diarrhea, they pooped once today. I'm not going to get excited if you've went to the bathroom one time. Have they changed their diet? Did they eat those greasy, high-fat foods that they shouldn't have eaten that's causing them to have diarrhea? What's worked in the past? That's one of my favorite questions to patients that are writing in, trying to triage them. What have you used in the past? Have you used it? Let's try it again. If it worked in the past, most likely it's going to work again. Have you tried anything? And then for me, one of my biggest things, if they're having true diarrhea, are they staying hydrated? Because if we're also going to deal with dehydration and diarrhea on top of it, there's more medical management that's going to go into that. And then we need to ask our nurses and ask our patients, when do we have to notify our providers? When is the diarrhea turning into something more than just taking Imodium or Lomotil? So are we having blood in our stool? Are we having foul-smelling stool? Did we just give them an antibiotic and they might actually have C. diff now? Is that the cause of the diarrhea, or was it their chemotherapy? And then dehydration symptoms. If they're feeling lightheaded, if they're feeling dizzy, do we need to also give them some hydration on top of it? There are a couple herbal supplements to avoid with diarrhea: milk thistle, cayenne, saw palmetto, and ginseng. But again, I tell patients, use what has worked in the past. Use what you have over the counter. Imodium's usually our go-to. I have not had somebody ask me about Pepto in years, and just recently somebody said, can I use Pepto-Bismol? Absolutely. If it worked for you, use it. I'm not going to say no to something that has improved your diarrhea in the past. Typically, we'll do Lamodal. I always educate patients. We have more tools than what is available to you. Over the counter, you can't get everything we can get. We can get you Lamodal. We can get you other medications if we need to help you. Similar to the nausea, we really need to be careful with our greasy, our fast foods, trying to avoid things that cause gas like beans and cabbage, carbonated beverages, which can make things worse for patients. Itching and rash for anybody who does immunotherapy. There's going to be a little talk on this in 30 minutes next door, so I don't touch heavily. We do have those chemotherapy medications that we know can cause rashes, Erbitux, for example, and we do have the kits that you can get from your drug reps to kind of help with the Erbitux rash. Taxotere is another one that I'll often see a rash with. You'll go months without seeing it, and all of a sudden something will pop up, and you know immediately they must be on Taxotere. My big thing is I need a picture. What does this rash look like? Where is it located? Is it actually shingles versus from their chemotherapy? Patients don't realize that they could have shingles. Are they on immunotherapy? It's going to be a little bit different of a triage and a little bit different of treatment that we're going to give for somebody on immunotherapy. And again, is it localized or diffuse? I go back to the old carts because I feel like that's the easiest thing for especially new nurses. It's something very simple to kind of go down the line for these nurses to ask the questions. Red, raised, flat. Can they describe it in their own words? Does it itch? Did they have a peripheral IV? Is it really an extravasation, or is it really a rash from the medication? And again, we need to know our medications. We need to know that they cause itching or rashes for when these patients write into us. And we need to know the medications that can cause that are irritants versus those that can cause extravasations. Deep vein thrombosis. When I teach on chemotherapy, this is one of my favorite things to talk about, because when you say it to a patient, you say a pulmonary embolism, you say a DVT, patients get very anxious about it. And I tell them, we know cancer, chemotherapy, and a port can actually increase your risk for blood clots. So most of our patients already have 3 increased risks. Plus, they're probably not going to be moving as much. They're not going to be exercising. They're not going to be getting up as much. So the reason I like to teach it makes everybody nervous. And I like to tell them it's so easy now. We just need you to tell us your side effects. We're not going to send you to the ER. We're not going to admit you. We're just going to start you on medicines. But patients need to be educated, and our nurses triaging these patients really need to be educated on what to ask for. When your patient writes in and they say, my ankle's swollen, is it both or is it one? Does it get better when you wake up in the morning, or is it there all the time? There's a lot of questions that they can really narrow down on DVTs to give us the right answer. So typically it is it unilateral swelling? Is it in the arm or the leg? Is it in the chest wall? I've had several people that have had chest wall swelling, and it's unilateral, and it's where their port is. Do they have a port? Do they have a history of DVTs already? And are they on anticoagulation therapy? Most patients will just stop with, hey, I have swelling. You got to dig deeper and find out where the swelling is it unilateral, and what can we do to help those patients? So peripheral neuropathy due to chemotherapy, the big thing with this is we know peripheral neuropathy can affect really all of the nerves, but it affects the nerve cell at the function of it. It can be concurrent with chemotherapy, or lately I've been having a lot of patients where it happens after chemotherapy, and they'll write in and they'll say all of a sudden my toes are tingling, and they think something's wrong. Well, if they just got 12 weeks of Taxotere, probably nothing's wrong, but we do need to work it through with them. I also like to know, did it come before chemo or is this something new with chemo? When we're going through teaching somebody, I don't typically say, hey, do you have diabetes? Do you already have peripheral neuropathy? Something I need to add to my practice, but it's something our nurses need to know as well. Some of this was already there, predated their chemotherapy. Common medications that we will see this with, your Taxols, taxane, vincristine, cisplatin, cytarabine, ifosfamide, and methotrexate. This is where I reinforce with nurses, you have to know your medications. You have to know which patients are on which treatments so you can properly triage them. The treatment for this is really going to be prevention and early identification. There are some research out there that says you should do cold therapy. You can go on Amazon and do chemotherapy gloves and socks, which can help prevent it. I agree with Troy, multidisciplinary. We got to get these patients into acupuncture, into intervention, into integrative therapies sooner. Then there's also pain management that we can do as the providers. Some of the non-pharmacological interventions, acupuncture, massage, guided imagery, meditation, are things that our nurses can say up front and say, hey, let me put this referral in for you. And while we work on it from the back end with insurance, let's see if we can get you some relief. I know I didn't give tons of solutions to the problems, but this is more for the nurses to really triage the patient and then come to the providers and say, hey, the patient's tried Pepto, Imodium, nothing's working. It doesn't have foul-smelling diarrhea. It's really to give the nurses an idea of how to triage these patients to come to the providers with a succinct roundup of this patient. So that way, as the provider, we can say, hey, let's try this next. And we're not troubleshooting with the patients. So I'm going to jump into oncologic emergencies. The main reason I kind of threw this in here, I was going to go straight side effects, is really I'm finding our nurses need to know when something's an emergency versus when maybe it can wait the 2 to 3 hours for me to get to. And I'll give you guys a perfect example. A few years ago, we had a young 32-year-old who had metastatic HER2 breast cancer. She said she had a headache. I had a new nurse at the time. She let it go till the end of the day. By the end of the day, it had been several hours. We called the patient. We actually asked her to go to the ER because we know HER2 metastatic breast cancer can go to the brain. It's much more likely to go to the brain than an ER-positive breast cancer. The outcome of that was actually my patient went to the ER with intractable nausea and vomiting and did not get an MRI of the brain. She came to see me the next day, got an MRI of the brain, and she did have brain mets. So even our ER did not triage her appropriately. But it could have all been handled differently. We probably could have gotten the MRI a day before had my nurse realized how important it was to let us know about this intractable nausea, vomiting, and this headache that had actually been going on for a few days. So we're going to segue into oncologic emergencies. The first one, neutropenic fever. I did have someone ask me the other day how to calculate an ANC. You can Google it, but if you don't want to, it's right here. I was talking to our girls at St. Charles. They said, you can also call the lab and they'll tell you what the ANC is. So I have two different models here. But with new nurses coming out, they don't always know how to calculate the ANC. So I threw it up here. Neutropenic fever, a little bit different depending on your myelosuppression and how long we anticipate you to be neutropenic for. So white blood cells have a half-life about 5.4 days, not super long, but we do know prolonged neutropenia is greater than 7 days. And again, know what regimens your patients are on. If you are in bone marrow transplant, you are dealing with a leukemic patient. If you're dealing with somebody who did just get discharged after an allo transplant, they're going to have prolonged neutropenia. We need to be prepared for these patients to be able to treat them quickly and appropriately. There's risk factors that go into neutropenic fever: age, chemotherapy agents you're on, previous chemotherapy or radiation, poor performance status, and comorbidity. Definition of neutropenic fever: single oral temperature of 38.3 degrees Celsius or a sustained temperature of 38 degrees Celsius for greater than an hour. I'm sure every institution kind of teaches this a little bit differently. I tell my patients, you have a fever of 100.4, I need to know about it. I don't care if it went down right away. I still want to know about it. I'm going to look at your regimen. I'm going to look at how many days ago you received this regimen. And are you in that nadir period? Are you in that 7 to 10 days after chemotherapy? Did you get growth factors factor. There's a lot that's going to go into it, but the nurse can really come up to me and have all of those answers. I don't necessarily have to ask them. My nurse can present those to me. Neutropenia is an absolute neutrophil count of less than 1,000. Severe neutropenia is going to be less than 500. Those, you're going to think you're bone marrow transplant patients. The reason neutropenia is so important, 10 to 15% of patients with solid tumors will have neutropenic fever. More than 80% of patients with a hematologic malignancy will have neutropenic fever. Our goal is to keep them out of the ER, out of the hospital. If we can catch it early enough to start them on antibiotics and do the workup outpatient, that is the best thing for the patient. It's the best thing for us as a treatment center. You can see here the mortality rate, if we don't treat within 48 hours, is about 40%. Our ultimate goal is to prevent septic shock, but really, let's keep them out of the ER. So prevention, hand washing, we know that's the best thing that we can do. But the way we typically work it up, 2 sets of blood cultures. If they have a line, I'm getting one from the line. I'm getting one from peripherally. I'm getting a chest x-ray. I'm getting a CBC. I'm getting a UA. My nurse doesn't even have to ask me. If my patient writes in and they say they have a fever, she can go ahead and get this started. The only part she really needs me for, the antibiotics. I don't want to know all of the other things. I want to know what their fever was and did we call them and ask them to come in so we can get this started. So this is just some of the antibiotics that we can use and when we use them. Hypercalcemia of malignancy, this one's much harder to triage. Honestly, usually unless they're right in front of us and we're drawing labs, we're not going to catch it. But there are those few side effects that patients may write in and say, or usually it's not going to be the patient, it'll be a family member. They're more lethargic, they're confused, they're having anorexia, they're not eating as much as they used to, they're constipated. So hypercalcemia of malignancy results from increased bone reabsorption from calcium released into the extracellular fluid. Actually occurs in about 20 to 30% of cancer patients. Your most common tumors, you're going to have your multiple myelomas, but then your metastatic tumors that go to the bone. So your breast, your non-small cell lung cancer, your head and neck, and your renal cell. It is a poor prognosis. Usually I find it's going to be a family member that's going to call in and they're going to say these symptoms. And a nurse needs to be able to be like, okay, this is worse than just regular, I just got chemo fatigue. This is something I really need to ask my provider, what do I do next? We're going to get a CMP. Most likely you're going to go to the ER unless my infusion center can get you some Iridia or Zometa pretty quickly. And then it depends on your level of calcium as well. Corrected calcium, the algorithm's right there. If it's really mild, we can treat it with hydration. Moderate hydration bisphosphonates, we can do loop diuretics. And if it's severe, we're going to end up admitting them. Another one that I find for nurses that we really need to make sure is on their radar is spinal cord compression. It is a neurological emergency. I think it can get kind of hairy between that and peripheral neuropathy. There's certain questions we can really ask to narrow down, is this peripheral neuropathy from Taxol or is this a spinal cord compression? And your questions, again, are going to be your old carts. When was the onset? When's the duration? What's the severity? Is it unilateral? Have you taken anything? And knowing your medications that you're getting. If it is a Taxol patient, you might want to ask a few more detailed questions. It is a common complication of cancer secondary to spinal mets. Spinal mets are the third most common metastases after pulmonary and hepatic. Majority of cases, again, are going to be the ones that are going to go to the bone. So your non-small cell lung cancer, your breast, your prostate, your renal cells. You will see it in non-Hodgkin's and multiple myeloma. Multiple myeloma, I believe, is about 5 to 10% of your spinal cord compression cases. One of the biggest complaints is going to be a new onset of back pain. That's about 83 to 98% of patients are going to say that they have a new onset of back pain, but that accompanying with a weakness and numbness, any bowel changes or poor ambulation, the nurses need to notify their provider. Again, for us, we're probably just going to send them to the ER because I need an MRI of their spine. I need to start them on steroids, which is on this side. So probably you're going to get admitted, but that's the difference between knowing when something is an emergency and notifying your provider right away as soon as they step out of a room versus saying, hey, this can really wait till the end of the day. Mets to the brain, I kind of already touched upon this with my poor little patient. Cancers that frequently metastasize to the brain, small cell lung cancer, breast cancer, in lesser degree, renal cell melanoma, and colon. Headaches, new onset, worsening, nothing's alleviating it. If they're taking Tylenol, they're taking ibuprofen, and it's not getting better, they need to come find your provider. Dizziness, vision changes, intractable nausea and vomiting, gold standards in MRI. Treatment's usually going to be steroids, possibly surgery and radiation. And lastly is bowel obstruction. Again, I think this one's a little bit hard to differentiate when you're just talking with the patient. Could it just be constipation, or do they have a bowel obstruction? And really getting a little bit more details using your old carts about when it started, the severity of it, and if you've tried things. But severe abdominal pain, severe cramping and sensation in the abdomen, throwing up, feeling gassy but unable to pass gas, constipation. I have the diagnostics up there, but those are when to go to your provider so that we can get them treated appropriately and quickly. If you think they have a bowel obstruction, please tell them don't eat. So we can kind of get the process already started once they're admitted into the hospital. But come to your provider. If you have questions, I know one thing we're doing at Ochsner is trying to have our APPs and our physicians onboard our new nurses when it comes to triaging. The way I like to be triaged may not be the exact same as the physician that I work with. So asking nurses, ask your providers questions. How do you like a patient presented? I'm one of those, give me their name and their MRN so I can pull them up and start looking while you're presenting to me. My physician is one of those, give me their name and just let me hear what you have to say. So we're all a little bit different in the way we like things triaged. I think really knowing when to get your provider and how to triage some of the side effects is very important. Now that patients have so much access to us, the back and forth between providers, it's a lot easier if my nurse comes to me and has everything succinct so I don't have to go so much back and forth with my patients. Any questions? Thank y'all. I appreciate your time.